So I have to say I am absolutely delighted to be here today for our first Nottingham and Nottinghamshire Integrated Care System Primary Care Network event, and wow, isn't that a mouthful? But I have to say, when me and Helen sat down to think about how this day might come to fruition, I didn't think we would see quite so many people from across the system, so it is amazing, so thank you. Can I also quickly say a thank you to our King's Fund colleagues who have worked with us to shape the event. We really hope that you enjoy it. It is more importantly your event, this isn't our event, so absolutely try and get stuck in. I think the secret to the success of the day will be the engagement and the conversations that you'll all be having. I've been asked to provide a bit of context about the work that's been happening in Nottinghamshire, and I thought some of you know me, some of you don't, so I thought I'd share a little bit about why I think what we're trying to do here today and what we're trying to create is so vital to our patients, our population and our communities. I'm a GP, I'm a local GP up in Eastwood, which is a part of Broxtowe, and I've been up there for 17 years. I am one of the clinical directors of a primary care network, and I also have the privilege of being the senior responsible officer, whatever that means, for primary care and our primary care networks for our ICS in Nottinghamshire. But to be fair, that's just a load of words on a page, that's just a load of titles that frankly sometimes don't really mean anything. And I actually thought it would be useful to try and give you some ideas of why I think what we're doing here today is so important, not just as a clinical director of a primary care network, but also as a clinical leader in our system. So bear with me because this could go one way or another. As I'm starting to have a bit of a talk about some of my reflections about why I think today is so important, I suppose my challenge to you is to start to think about why you're here today. And that's not just because we sent you a nice email inviting you to come and you thought, wow, that looks interesting, but more about why this really matters to you, why you're interested in this as something that you might want to take forward. What's your story if somebody asked you today or later on? So this brings me to this picture, and you might think, why am I sitting looking rather sweaty on a bench? And frankly, I'm a big runner, so I usually somehow manage to try and get that somehow in my conversations, but actually today it's not about that. This is about my story of John and John's bench and what it means to me. Now, I did start to think about this last night, and actually, because it's quite a personal story, you'll have to forgive me if, as I start to talk about it, I get somewhat emotional because it does have some real meaning. As I've said, I'm a GP that lives in Eastwood and have been up there for a number of years, and through that I've had the privilege of getting to know a lot of my patients. I met John and his wife Barbara 17 years ago when I started as a shiny new energetic GP who was ready to take on the world, and actually since then we've grown up together. I've listened to John's story as he came to talk to me about his back pain and how that was affecting his work as a self-employed plumber. We've laughed and joked about how his dodgy knees were affecting his ability to climb mountains at the age of 70. And I was there to discuss his referral to the hospital when his chest x-ray just didn't look quite right. And then I was there to help with him and his wife coming to terms with his diagnosis of cancer when we found out he had something called malignant mesothelioma. I had the pleasure and the pain of being part of the integrated team that was mobilised to try and help support them both. We had some fantastic responses from our district nursing teams, from our Macmillan nurse, and latterly from social care, to look at how we wrapped around care to provide for his needs and Brenda. I was also there when I received a very panicked and tearful phone call from Brenda to say, can you just come, Doc? I need you to see John urgently. And when I got to the home, I found that John had tried to hang himself in his garage because he was struggling to come to terms with his deteriorating health. I have to say I can still close my eyes now and remember walking into his bedroom and seeing him sitting on the bed and looking up at me and saying, I'm really sorry, Doc, I couldn't even get that right. And sitting and holding his hand as he struggled to confess how he was feeling. The amazing support from our Macmillan team and from Haywood House in supporting the family, as well as us, who were looking after him to come to terms with what we needed to do, meant that we could provide John with the needs that he required. And I'm pleased to say that John died with the dignity that he wanted in the place that he wanted and was a true gentleman to the end. And I have to say I was privileged to be part of his and Brenda's journey. So this really matters. It matters to me, it matters to the populations and the people that we serve. I suppose John's story reminds me of why we're here today and why I think what we're doing and what we're trying to create really matters. I get to go past John's bench a lot. I luckily live where I work. So on a day when I've had a bad day, I sometimes put my trainers on and go out for a run, and will wend my way towards John's bench, sometimes have a bit of a chat about how rubbish my day's been, but also to sort of kind of get some of the essence of the joy of knowing such a remarkable person, but also some sense of hope that when we get this right, when we truly get this right for a patient, it can be magical, not just for them and their families, but for the people that are working for them. So I suppose I'd like you to hold that thought for today. That's why I'm here. That's why I'm really passionate about what we're trying to do, what I'm trying to do as a clinical leader. But I suppose the question would be, that's part of my journey of why I'm here today, but I'd like you to have a think about what your journey might be, what your story might be as we go through the presentation, but also as we go through the rest of the day. So what I actually was asked to come to talk to you about was the journey so far in Nottingham. And actually, we're not starting from scratch. As the team said before, we have had 4 vanguards across Nottingham and Nottinghamshire, so we're not starting from ground zero. And actually, we have been trying to build on this work through work that we have continued to do. I won't go into this in great detail because actually some of this has been covered in the last presentations, but actually the work that's happening on primary care builds on something called the GP Forward View, which was a national NHS England directive, which was looking at trying to ensure that we could make general practice sustainable and resilient, looking at how we could make a future-proof, I suppose, primary care for the future, look at how we might improve population health, and also start to think about how we might use our system resources better. And again, some of the pillars that underpin this are up on the slide, but again, hopefully nothing that none of you in the room are not familiar with. Again, this has been covered, but just to really reiterate what a primary care network is and what we're actually trying to build and create today and for the future. And again, I'm happy to say that the Nottinghamshire ICS slide on how we think our system works is not hierarchical. Actually, this is part of a really complex jigsaw piece puzzle of how we all work together. And actually, for this to be a success, we truly do have to work together, from our neighbourhoods to our places, across the whole of the system. And actually, the primary care networks will be the critical, I suppose, driving force about how we do some of the stuff around John differently in the future. So again, rather whizzy diagram, and I'm afraid you can't really see it, but we will make sure that these slides are provided at the end. But actually, we had before primary care networks actually came into fruition, we had done some thinking as an integrated care system about how we might see a primary care network looking in the future. And that would be obviously at the population of 30 to 50,000. We do have networks that are bigger than that. But again, looking wider at how we provide care coordination for our patients, how we use multidisciplinary teams, how we use our additional roles through social prescribing, pharmacists, how we start to develop relationships with our wider partners, such as community pharmacists, acute trusts, mental health providers, community teams, to really start to look at how we wrap round the patients that live in our neighbourhoods. And again, this is, I suppose, a visual slide to say what we think some of the core principles of our networks will be. Again, we've talked about how there's funding for clinical directors, additional staff, and some funding that's going to go to the networks to try and help to, I suppose, be the glue to make this happen. Now, at the moment, a lot of the work is happening around sort of general practices coming together, because actually this is a bit of a game changer. I know that there are lots of places in Nottingham and Nottinghamshire that have been working together as GP practice for a long period of time, but we maybe haven't seen that happening across the board. And so there's a lot of work now about linking together those general practices to start to get them to think about how they might work differently together and how they might collaborate. But actually, as we know with the specifications that are coming over the hill, we are going to have to start to think about how we look wider, how we face outwards, and how we develop those relationships with wider partnerships, such as GP federations, community teams, mental health, local authority. This isn't an exhaustive list, and actually some of this is what the art of the possible is, and what is the appetite for our primary care networks to take this agenda forward. Again, we've talked about place. And there are 3 places in Nottingham and Nottinghamshire. We have Nottingham City, Mid Nottinghamshire and South Nottinghamshire. And again, just for those of you who know this or don't know this, in Mid Nottinghamshire we have 6 primary care networks. In the city place we have 8. Again, we can make sure that these are available to everybody at the end. And in South Nottinghamshire we have 6 primary care networks. Again, just to give you a little bit of context of where we are as a system and what we think our system priorities might be, a lot of work has happened on our integrated care system long-term plan, and these are the priorities that we've set out as part of that plan on priorities that we need to work together to see whether we can improve things such as prevention, the wider determinants of health, proactive care, emergency care, mental health. None of this should hopefully be unknown to all of us, because actually if we think about how that works in our daily lives, actually these are the things that are the bread and butter of what we do. So what do we think success might look like? And actually, as they've said, there's no blueprint for this. So, how are we going to know whether we've done what we set out to do? And actually some of that is through some of the conversations that we are going to start to have today. And actually, try and define what does success look like for us, for Nottinghamshire. But essentially, I suppose the idea is what we're trying to achieve is better integration across our communities, ensuring that we have developed a more resilient and sustainable general practice for the future, starting to think about how we can make our workforce feel more collaborative. Again, like today, we've taken off our lanyards. How do we really work for our populations? How do we put them first before our own organisations? How do we really make prevention happen? We talk about it a lot, but actually, how do we really make every contact count? How do we really make it part of everybody's job? How do we start to have different conversations with patients and start to ask them what matters to them, rather than thinking about what's the diagnosis and what's the management plan? How do we really start to engage with citizens and with patients to start to think about how they own their own health and well-being, and how can they become engaged in the agenda that we're trying to set around our networks? And how can we start to think about how we be more proactive rather than reactive, and start to think about how we target our interventions against the needs of our population? I have to say, this is quite a huge agenda, and this isn't going to happen overnight. So again, it's thinking about how we start to work some of these things through and how we might plan that for the future. And that's all I have to say. So hopefully, some of this might ring true. As I've said, I'd be really interested to speak to everybody later on as to what they think has brought them here today, and hopefully continuing the conversations that we are starting to have. I'll hand you over to Julian,